I'm Sabariah Faiza, right? As the Egyptians, as I was trained in Egypt, so they always call doctora, right? So it's not something that is being called doctora. It's not something unusual for me. All right. So thank you, Dr. Yara, again for inviting me to give this talk to your group in Saudi Arabia. I appreciate it very much. I'm an emergency physician, but I treat mainly adults. I treat mainly trauma. I treat adults. My area of interest is actually in trauma, and again, as around the world, we don't see that many that many pediatric trauma, but that's why I think having pediatric emergency medicine development in your country and starting off also in my country, looking at pediatric trauma is something that the pediatric emergency group really have to look at. Okay, so to start off with, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Trauma is not something new. We know that it's been there for a long time. And what I would cover is just quickly about the global burden of pediatric trauma, some of the pitfalls in treating pediatric patients, management and resuscitation, and imaging in pediatric trauma. I think this is a very important part when we manage pediatric trauma, and some future directions in managing or in pediatric trauma. As you can see from this slide, can you see my slides well?
Yes, we are.
Right. If you see all the darker blue areas, right, those are the areas that have high trauma outcomes or causes of death by injury. If you see Saudi Arabia there, very dark, very dark blue, very high, right? Right. And look at Saudi Arabia, 19.46%, right, of the total death is from injury. So as compared to other areas in our region, in Asia, since we belong in Asia. So if we talk about the disease. Okay, so I was looking at the burden of disease in Saudi Arabia, right? And I came out with this document, the burden of disease in Saudi Arabia, using the global burden of disease methodology. That's the data they get from the WHO. If you look at this graph, you have increase in number of patients death from injuries, right? In more of the adolescents and the young adults between 15 to 40, and increase in the number of deaths. If you look in the pediatric grade group between 5 to 9 and under 5, it seems to be quite low here, right down here. Don't seem to be going up trend, and I think that's a good sign that whatever that you're doing for the pediatric patients in Saudi Arabia is doing the right way, especially death from the motor vehicle accident, which is the main cause of death. If the pediatric in the Middle East, right, 12% of the global unintentional death in death is in the Middle East and North Africa. So we're talking about having injury in the Middle East region and the North African region is a serious situation that not only us as doctors and physicians in the hospitals have to take care of, but something for the government to realize that trauma and injury is something that we have to take care of, have to look into the causes, how to prevent it, because the best way to prevent death and injury in trauma is prevention. And the same thing that we can focus on prevention of injury in the pediatric age group, the use of seat belts, the use of car seats, wearing helmets when they're on the bicycle, good, safe playgrounds, all this can contribute to the decrease in death in the pediatric age group. Right. Here just shows that in 2021, if you look at the high-income Asia group and the Middle East, Southeast Asia group, where we are in Asia, fortunately, between 1990 and 2021, there is a decrease in the death from injury. Unfortunately, most of the patients that die are under 5 deaths, right? And these are unintentional deaths, children and adolescents. A lot of them are pediatric patients. So this is data from the WHO that they have. Now, Lee et al., they are part of the Pan-Asian Trauma Outcome Study. Pan-Asian Trauma Outcome Study is a registry that includes, that collects data from many countries in Asia. We combine them with the center in South Asia, and we come up with the Pan-Asian Trauma Outcome Study. So Lee et al., when he looked into the unintentional injuries among countries with different economic status in Asia, right, we found that the traffic injuries and falls are the most common kind of injuries in Asia. If I'm not mistaken, Saudi Arabia at the moment is not part of the PATAS community, so they do not contribute data for the Pan-Asian Trauma Outcome Study. So this data from Asia that does not include Saudi Arabia. So most of the injuries are from traffic injuries and falls, and most of them again occurs on the highways, on the streets, home, including the gardening, and outside the house. So somewhere around in your community, outside the house. So this is what we see mainly in most of the other Asian countries. And most of the injuries are from the head and the face, and with the upper and lower extremities. Now, even as trauma specialists, even for me, when we have a pediatric patient that comes to me, managing this patient for trauma, right? Our default thinking is adult thinking, right? And sometimes we used to think that, we treat them as a small adult, right? So again, that's the main pitfalls in our way of treating, and something that we have to change our mind. And I think what you guys are doing, having CMEs and trying to get your country knowledgeable about how to approach pediatric patients, and not thinking pediatric patients as a small adult or a young adult. Okay. Now, if we look at the airway and breathing, children, as we know, desaturate very fast. So their chest wall is very compliant. So they don't fracture their ribs very well, right? But they can have very bad lung injury, right, underneath the chest. So a normal chest X-ray does not rule out a pulmonary contusion because of the compliance of the lung. So if a trauma patient is hypoxic, the kidney, we should assume that something about internal chest trauma until we prove otherwise. For blood pressure, right, you all know that hypertension is always late in a pediatric. They will compensate, and then suddenly go to bradycardia and die. I mean, it happens to me before. I had that situation a couple of times in medical and surgical outcomes, right? So we tend to think that, since the child has a normal blood pressure, the child should be okay. But basically, if we look at child as a whole, they are not there. And then we tend to use adult GCS, right? So instead of having age-specific GCS, and for imaging, we tend to over CT scan. We love the CT scan. I myself love the CT scan, but again, all right, the adult triggers should not be used for pediatric triggers. If you look at the collar and board routine in the trauma adults, in children, it's more of ligamentous injuries. So immobilization because of how the airway is can actually can cause some sort of obstruction for the airway. For equipment wise, a lot of in some hospitals, even in my country, right, we don't have equipment specific for pediatric patients. So we tend to use adult equipments for pediatric. For example, we use adult laryngoscope. Sometimes we use a big collar for the pediatric, for the adolescents, right? So we don't use the proper drain. So in that case, we don't have the proper equipment. So we therefore are not managing this patient very well. So there's a lot of pitfalls when we are managing a pediatric patient, especially thinking that using your adult mentality in treating the pediatric patient. Okay, then I'll go into some of the updates on resuscitations, thinking about initial assessment, just mention about a bit on the tranexamic acid, damage control resuscitation, and something about which I find quite interesting is the pre-hospital blood administration. The initial resuscitation of a pediatric patient, of a small patient, is the same, right? The concept is the same as adults. You stop the bleeding, you stop the exsanguinated vision, you manage the airway, you manage the breathing, circulation, disability, exposure. So there is no difference in adults and in children. Okay. So the latest guidelines, ATLS guidelines came out in about second half of last year, the 11th edition. What did they mention about pediatric trauma? Right. So there has bigger focus on evidence-based resuscitation. So now those were the days when I first started ATLS. Those were the days. You give 2 liters of fluids, you give the child 30, 40 mils per kilo of blood. So, but they're getting more updated, right? So the 11th edition mentions more of giving these the O negative of safe blood, having the transfusing blood in the ratio of 1 to 1 to 1. You trigger a massive transfusion protocol early on. They highlight about pain relief, which we tend to forget, in a child. We think that they're crying because they're scared rather than they're in pain. And there's a lot of team dynamics, communications, having checklists, and again, reinforcing the core principles like recognizing children's unique physiology. Different children of different age have their own unique physiology and anatomy. So these are part of the new focus of the ATS edition. Okay, so what about anything new in giving tranexamic acid in pediatric patients? Ever since the CRASH 2 and CRASH 3 trial, giving tranexamic acid has become a norm when we receive when we receive our adult patients, and we have moved also to give tranexamic acid empirically in the pediatric age groups. Usually, we will give them about 50 mils per kilo, 50 milligrams per kilo, followed by 2 milligrams per kilo per hour over 8 hours period. And this is what our pediatricians also give in the sense of for our pediatric patients. But is there evidence out there that this dose is effective in the pediatric patients, and whether tranexamic acid itself is effective? Most of the studies of tranexamic acid in pediatric patients comes up from the war in Afghanistan and Iraq. So most of them are retrospective and a different type of patients if you were to compare them with the usual group of blunt injuries that we get. So most of them, they get blast injuries, penetrating injuries, right? So, and most of this, the military, the studies on transaminases are from the military. By looking at the civilian side, right? I'm sure some of you are familiar with the TikTok study, traumatic injury clinical trial, even tranexamic acid in children, right? So what is a pilot trial? I'm not quite sure whether they have moved this to an actual trial. So this was just a pilot trial. So they have three groups: the tranexamic acid, usual dose, 15 milligrams bolus, 2 milligrams infusion. They double the dose, 30 milligrams bolus, 4 milligrams infusion, and a normal saline placebo. So this is a pilot randomized, double-blind, randomized control trial. And what they found was there was no difference in the outcomes. Now, we cannot say that there's no effect of tranexamic acid because this study is not powered. Most likely, they actually want to see that whether it's feasible to do such studies, feasible to do a randomized control trial in this pediatric group of patients looking on the dose of tranexamic acid. All right. So it seems to be okay. It's difficult to do. So I'm not quite sure that whether they actually proceed to do the actual clinical trials or not. Maybe those of you who knows can please update me. So one of the next best thing for you to do is to do systemic review of the effects of tranexamic acid on children, right, in traumatic bleeding. And the outcome is that it significantly decreased mortality, especially initial dose of 1 grams. In adolescents, it could be 1 grams or about 15 milligrams, 15 milligrams per kilo. And sometimes they even go, if we look into the military, they go up to 2 grams of tranexamic acid. But with 2 grams of tranexamic acid, there's slight increase in seizures. But overall, when they look at the systemic review, tranexamic acid significantly decreased mortality in the pediatric age group. Again, most of the studies, or nearly all the studies, are retrospective studies. Okay. Now, the other part of resuscitation is doing in the pediatric group is doing damage control resuscitation. So we're talking about permissive hypertension, minimization of crystalloids, give the blood products in 1:1 and 1 ratio, and give the blood products early, and very early hemorrhage control, right? So permissive hypotension, some mention again about permissive hypertension in pediatrics, but it's not recommended at this point in time. Early hemorrhage control, yes, we stopped the external hemorrhage as much as we can, either by tourniquets, mechanical, topical, and given IV tranexamic acid. We minimize crystalloids, right? 10 mils per kilo of crystalloids in our initial resuscitation, and up to about 20 mils per kilo if they are responders. But if after your 10 mils per kilo of crystalloids, there's no effect, we go straight to giving this patient low titer group O blood. And if we have message transfusion protocol, or we can get the blood in 1:1 ratio, this is the time that we give this patient not too much fluids. Again, the basic principles the same as adults with a bit of tweak, right? But no permissive hypertension now, not recommended in the pediatric age group, minimize the crystalloids. Now, damage control resuscitation in pediatric patients, I've not found any randomized control trial. Very difficult to do. You know, it's not like we do a proper trial looking at the blood usage. So they have a very vulnerable age group. But I found this one study looking damage control resuscitation in pediatric trauma patients from the Pakistan. So they really actually I really wonder how they got this through the ethics. Okay, so they had 50 patients, right? Which is half and half. The average age is about 7 to 8 years old. And if you look at here, the mortality is significantly decreased in this patient if they do the damage control resuscitation. They did actually in their paper say what damage control resuscitation that they do. They just mentioned do damage control resuscitation. Right. So 7% versus about 27%. That's massive. Right. Right. And when they look at the coagulopathy, right, those patients in the sorry, this is the other way around. Yeah, those patients in the DCR group have about only 3.5%, 3.5% of coagulopathy compared about 21% in the control group. So this is the only so far randomized control trial looking at damage control surgery that I can find in the pediatric age group. But again, I think I personally have to think about this study with a bit pinch of salt. Now, what about pre-hospital blood transfusion? Okay. The PAMPER study, in which the patients are given thawed plasma when they're transferred or they're being brought by the air helicopter, by the air ambulance service to the trauma centers, right? So when they found that when they give the pre-hospital care, pre-hospital patients thawed plasma, it was safe. And there was a lower 30-day mortality than if they did standard resuscitation, where they did not receive just standard care but no plasma. This is a randomized control trial. So they randomized, once they got a call to transfer this patient by the air ambulance, they randomized this patient to either receive plasma or no plasma. Now, so this is one of the randomized control trial that we have, but this is an adult. We have randomized control trial in children looking at pre-hospital, no, we still don't have. The cessation of hospital transfusion with mortality by Morgan et al. With her group, looking in retrospectively looking into from the Pasadena Trauma System database between the age of 0 to 17. So they went through the retrospective study, and so they look into children who received pre-hospital care blood transfusion and compared it to patients who just received the blood in the ED. And so when they found, which probably we can expect, that the pre-hospital transfusion will lower rates of mortality and compared with transfusion or arrival to emergency department, and even lower rates of 30 days mortality compared to if they were to receive blood in the ED. So somehow or other, if we were to give blood, they give packed red cells. So you give packed red cells to the bleeding pediatric age group in the pre-hospital care environment, they do much better. Again, retrospective trial looking into their trauma registry. And then the logistics of getting blood products are complex. I'm sure it's complex for us. I'm sure it's complex for you guys. But I think in later on, unless they can find a replacement for red cell, the technologies are there to find replacement for red cell, to find replacement for blood. Maybe more and more ambulance service will start carrying packed red cells or even plasma in when they respond to severe trauma cases, whether it's adults or pediatrics. And retrospective studies have shown that for pediatrics, it works very well giving blood in the pre-hospital care environment. Trauma imaging in pediatrics, this is a big group. This is what we usually do, that we want to do. But we have to remember this principle, ALARA principle, as low as reasonable, achievable, right? So when we have a patient that comes in, right, first thing in our mind, we have to ask, does this child need imaging at all, right? Now, if the child needs, okay, then we ask, which anatomical area do we need, instead of just doing everything, right? So whole body CT scan is not for pediatric patients. And then if we do contrast enhanced CT, it can apply judiciously. Okay. We know that if the pediatric patients receive X-ray radiation in the early part of life, right, the incidence of getting some form of cancer later on in life is always there. Okay, and if you decide to do imagings, especially a lot of imagings, CT scans or MRI, there must be a senior level communication for decisions. So if your registrar out there, your residents, young junior officers, please consult if you need to proceed for more X-rays for these pediatric patients. Always remember the ALARA principle, as low as reasonably achievable. Right. The X-rays are really not good for the child. So these are the guidelines, the major, recent major pediatric guidelines from the Royal College of Radiologists of UK, right? Now, this something about you all are very familiar with, the PECAN rule. There is the Pediatric Emergency Care Applied Research Network, right? When you decide to do CT scan on a child, 2 years over or 2 years younger, just follow the PECAN CT rule. Because it's been proven, it's been validated, right? So look at this carefully, study it carefully, and at best, follow it so that we will decrease the unnecessary imaging to these pediatric patients. Routine whole body CT has become routine in adults. We have started in a hospital I worked before. Whole body CT has become a routine, but of course with certain indications. So a lot of patients do get whole body, but adults, right? But not in the pediatric age group. It should not be performed, right? So don't ask for whole body CT. Target what you want. If it meets the HCT rule, target your organs that you want to do the CT scan. So for this is the HCT, right? Now, we can also have the intra-abdominal injury, right? So they came out with the intra-abdominal injury rule. And as of recently, they have recently validated this skill, right? To look into the imaging if we suspect intra-abdominal injury. Okay. So the good news is it has a very, very good negative predictive value. So if this patient has evidence of abdominal wall trauma, there's abdominal tenderness, there's evidence of thoracic wall trauma, complex abdominal pain, vomiting. So this patient is not a very low risk and you should consider having intra-abdominal imaging for this patient. If all of this are no, then patient is very at low risk. So this, we can use the PECAN intra-abdominal injury. It's been validated in the latest is 2025. They validated and published it in 2025. So the PECAN rule for cervical spine is also new. This is, I think, one of the latest. So this is based on the EMS observations. Before that, they look into patients which have already admitted to the ED. So for the cervical spine, they look into the observations for the EMS, whether they need to do a CT spine imaging for these patients, right? And then using these rules, it's again very good. Negative predictive value of 99.7%, sensitivity of 88.57%. So if you look, if the GCS is low, right, you consider CT. If it's between the moderate level, you consider X-ray, right? Look for neck tenderness, examination, right? And if there's no risk factor, you consider clinical clearance for your cervical spine rather than imaging. So the PECAN rule and the principles, I mean, you can other use rules, the Canadian spine rule, there are other many rules, but I think using a PECAN rule is also good. But the choice of is yours to use whatever rules there is that shows its effectiveness and validity, right? Okay. Our good friends, yeah, the fast, the ultrasounds. It's come to my time that, you know, my residents and my doctors will get hold of the ultrasound and the what do you call that? Get hold of the ultrasound even before touching this patient. All right. What about clinical evidence in a child, right? In the pediatric age group, a lot of studies that comes out. Accuracy of focus blend. These are all very, very new, new findings. Focus assessment, creating early surgical interventions, right? And there's limitations. They're different from adults. When all of us learn how to do fast in adults, right? And then we translate what we learn in adults to the child to do fast and e-fast, right? It's again different. You need to be cautious because there's low sensitivity in the abdomen, especially the main thing look fast is to look at the abdomen. Many miss intra-abdominal injuries. The younger you are, the less sensitive it becomes. Okay? And sometimes the physiological fluid can confuse the results because children need more blood for a positive fast as compared to the adult. Operator dependent, of course, in adults, it's also the operator dependence, but in a child, the different age groups of the child, the different size of the child, you have to know the anatomy of the different age groups. So there's a very skill and it requires a lot of training to do that. If you have a negative fast or you fast, it is not definitive for abdomen. Okay, a negative scan does not rule out an intra-abdominal injury. Please remember that, right? You need to follow up with either clinical observations or some other imaging techniques or modalities if it's required. Okay, and in summary, fast components, fast is not sensitive. Fast and e-fast not sensitive. You can increase the sensitivity by doing it serially, not as a one go. In adults, we find fluid in the abdomen. That's it. We got fluid in the abdomen. Okay, right. Then we send the patient for CT scan. In a child, right? Initially, it might be negative. If we do it serially, we might be able to catch the bleeding occurring. So it becomes more sensitive if you to do the fast or e-fast serially and compare it with the full blood count. And then with if you add e-fast to it, e-fast is still also relevant to look into the to look into the pleural space and to look into the pneumothorax if you get. So summary, fast and e-fast is good, right? But please understand the limitations and challenges in the pediatric age group. Okay. Right. A few more slides left for future directions. AI, right? Enhanced detection can predict mortality. They've got some of the things there. I'm not quite sure how it works. I'm not an IT person, but I think they're still working on detection of injuries. Maybe for the X-rays, if you put in certain data, it can give you an area of suspicions. Again, a lot more work to be done in the pediatric age groups. Biomarkers in pediatric traumatic brain injury, I've not measured specifically traumatic brain injury because it's one whole big subject by itself. Traumatic brain markers like GFAP, S100B, UCH11, many things. Some of them are unpronounceable, right? It can show promise and in predicting outcomes in pediatric patients, right? Because what it does, it measures brain scale damage in the blood or CSF. But it's still a lot of questions that need to be answered, right? Can you use a single marker or using more combined markers will be better? and the and they've postulated also, and I think they've shown that brain development in children affects biomarker release, right? So, and that requires specific research, right? So whether if you have a raised biomarker, is it due to the child normal brain development or just due to some traumatic brain injury? So a lot more studies that need to be looked into biomarkers in TBI. Use of viscoelastic studies, very much widely used for the adult age groups, not so much in the pediatric groups, but they have been doing it. I've not touched about it also, but in some of the major centers, they're using the viscoelastic studies to have a more accurate replacement of the blood and blood products of the pediatric patients rather than empirically that we can give to adults, because we can't give empirically to a child. You still need to be based on the body weight of the child. So in a child needs to 10 to 20 mils per kilo of your blood and blood products, right? But in adults, we just give 4 units, 1:1:1 ratio. So if you want to titrate the blood and blood products, I think one of the use of the viscoelastic studies in the pediatric age group should be good. And I think this area of research is going on at the moment. And if you do have TEC or ROTEM in your department, please share your studies with us. Again, it's not easy to do randomized control in pediatric resuscitation management, in acute management of resuscitation, right? So you need some brave people out there. You need people, you need good studies that will not invariably harm the child, right? So with that, I can summarize it that in managing the pediatric trauma patients, we prioritize early life-saving actions over diagnostics, right? And then when we use some diagnostics, especially imaging diagnostics, we use the ALARA principle, use some of the rules. For example, the PECAN rules, judicious CT scans, no limitations of the ultrasound that you're using, and you can apply damage control principles. Stop the bleeding, keep the patient warm, balance resuscitation, early blood transfusion for the bleeding patients. And of course, we need further research. In the pediatric patient. With that, ladies and gentlemen, I thank you for your kind introduction, kind participation, listening to me talking about this topic. Shukran jaziran. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr.
Questions, there is. I'll stop sharing.
Yeah, please. Thank you so much, Dr. Sabariah. It was really an inspiring talk and presentation as well. Let's take some questions from the audience. So, anyone has a question? Actually, from my side, I have a couple of questions I would like to ask you, since you're an expert in trauma. What are the most impactful recent updates in pediatric trauma care that have changed frontline emergency practice?
Oh, that's really a big question.
Yeah.
If I'm not looking at Malaysia there, if you look at the more developed countries, having dedicated pediatric trauma areas where trauma physicians and surgeons dedicated to pediatric patients manage these patients, right? Such dedicated trauma centers for the pediatric patients, right? I think, right, and I'm sure that the evidence out there would help in managing this patient, because if there's actually not that many pediatric traumas that we have, right? I think even for your country, just goes on the baseline as compared to the young, right?
Yeah.
So if they're sent to any hospital or the nearest hospital, when are you going to get the experience in training them? To train your residents, to train ourselves in managing trauma patients. So if you focus having the pediatric patients, right, in a single center where you're going to get volume now you get to know you have the basic equipments, you have the facilities, and you have, because of the volume, experienced people managing pediatric patients. I believe
Okay.
if it's good for adult having trauma centers that manage adult cases, why can't we have it for pediatric patients?
Okay.
Which
Amazing.
body, right?
Yeah,
Right. So
you're right.
it's probably a few more years down the road, but
Yeah,
right.
of course. So you're advising for specific pediatric trauma centers that it will help actually to impact our pediatric emergency cases, especially in trauma cases. That's amazing. So there is a question from Dr. Alia about the initial IV fluid amount in trauma cases. Is it 10 or 20 ml per kg in pediatrics?
Okay. The ATLS mentions 10 mils per kilo, and then if it's a non-responder, proceed to give transfuse blood. The advanced pediatric life support, the APLS, when they're talking about management of the injured patients, they say you can give another bolus of 10 mils per kilo
Oh, okay.
of
Amazing.
crystalloids. But personally, I would go just for 10. If
Okay.
there's no improvements, I will go for blood early
Oh,
because
okay.
for when talk about damage control resuscitation, we want to give blood as early as possible. And that study that shows if we give blood in pre-hospital care, patients do much better, right?
Yeah.
So so we should give them the blood early in the ED once they reach us.
Okay.
So
Especially if we're
even some studies say about 10, some say 20. Put it 10 and then proceed to the blood at 10 mils per kilo.
Yeah, okay, amazing. Especially if we're dealing with crystal clear hemorrhagic shock cases. So we're advising a 10 ml per kg and then followed by blood immediately. That's amazing. Another question. Initial shock manifestations is tachycardia, which can be non-specific in pediatric population. Can we start blood and tranexamic acid without waiting?
Okay. So a very good question. I'm not I'm not I'm not quite sure you should give blood first, right? Until to find out that the cause of tachycardia is hemorrhage. As we said just now, start with 10 mils per kilo first and see how the patient responds. That the heart rate comes down, right? If there's the bleeding have stopped, if you're giving your initial 10 mils per kilo, that will bring down the blood heart rate a bit, correct? Now, what's the second part? Sorry.
Second part, can we start blood and
Tranexamic
tranexamic
acid.
acid without waiting?
Right.
Yeah.
Yes, you can. I would start tranexamic acid if I suspect trauma. If I suspect patient has tachycardia or poor perfusion due to bleeding. That's what the crash 2 did. The crash 2 trial, when they did the trial, it's not sometimes obvious injury. On the clinician's input, if the clinicians thought that the patient is hypertensive through bleeding, you can start tranexamic acid. And tranexamic acid has been proven to be safe even in the pediatric age group, right? The 50 milligrams per kilo followed by 2 milligrams per kilo per hour. The higher dose you give against the risk of seizures, but thromboembolic phenomena is rare. So I believe, right, and I think the evidence do point out that it is okay for you to give tranexamic acid if you suspect either head injury or hemorrhage as the
Yeah.
cause of your tachycardia.
Okay, amazing. So what I have noticed that you have brought up the TikTok trial, which is really amazing. But however, still in the trial, they did not came with conclusions in regarding to the low doses of TXA, along with the high doses of TXA. But they have mentioned it clearly in their trial that they can induce seizures, which we have to be cautious as pediatricians in dealing with pediatric cases. In regard to the crash trial, I have went through it actually, and it's purely adult trial rather than pediatric. But as you said in your presentation, most of the studies are in adults and then they
Yes.
deploy it in pediatric. But again, I can't emphasize more what Dr. Sabariah said, that we need to be cautious in pediatric patients and applying the adult researchers or evidence-based medicine in pediatric because they are not fit for pediatrics unless we get a senior consult with their experience. Okay.
I would suggest keeping the dose at 15 milligrams per kilo rather than 30 milligrams per kilo.
Yeah.
Right. Because they were looking at the military side where they use some groups they give 1 gram, another group they give 2 grams in more of the adolescents age 16 years old, 15 years old, already adult size. Right.
Yeah.
And it does there's a slightly increased incidence of seizures. The usual dose have been shown to be effective. Let's just keep to that, right? And then our 50 milligrams per kilo is good enough, I think, at this
Yeah.
particular point in time.
I can't agree more. There's another question by Dr. Altaf. He says, do we have a clear guidelines in pediatric when to start massive transfusion protocol? And in case we like to start transfusion early, should we overlook guidelines?
Okay. There's another good question about massive transfusion protocol in adults, in children. The ATLS guidelines do mention now having an MTP for the pediatric age group. Our pediatric, we don't have many pediatric hospitals, specific pediatric hospitals in my country, right? There's about only 3 dedicated pediatric hospitals in my country, right? And the biggest is in Kuala Lumpur. So only now they're talking about how to come out with the MPT guidelines.
Uh-huh.
Well, the hospital is pretty new. It's about 5 years old. So, right. So they're developing protocols over there. So they're looking into how do we, what are the things that we need in massive transfusion protocols in pediatric group. We can't follow blindly what the adults do, right? But I think we are um, uh, following blindly the 1:1:1 ratio. We have to
Okay.
do that because we no longer have whole blood to give to the child or give to the patients, right?
Oh,
So the 1:1:1 ratio, right, seems to be the blood and blood products that are going through also the same as adults, right? So when we do MTP for the pediatrics, it's there are a lot of ifs and when considerations because you've got from an infant to an adolescent, right? While adults are just adults. Just give
yeah.
them, yeah. Adult MTP, 4 units, plasma, 4 units, packed red cell, 4 units, platelets. Just give it to this patient. It's okay. We can't do that for the pediatric patient. Right. There are some guidelines out there, and some centers have using pediatric MTPs. We're just developing ours, and but I think it's good. Go ahead and look into developing a massive transfusion protocol for your trauma patients. I think it speeds up getting the blood early because we want to transfuse the blood and products as early as possible. Right? I
Okay.
hope that answer your question.
Amazing. But Dr. Sabria, have you came across international guidelines, let's say in very developed countries like US and Canada, and regarding the MTPs in pediatrics? And if so, can you share it with us?
I've not actually looked into that,
Uh-huh.
but if one, I can always ask my pediatric emergency specialist friends
Yeah,
to give it to
definitely.
me.
Yeah,
right?
please. That's
Yeah,
a great
I thought,
thing
yeah,
that
but
is.
there are centers that developed, and according to my friend, even to share even my country's main pediatric hospital, that then that we can share with you.
Yeah,
I can send it
yeah.
to Yara. You can share with the group if you find any
Amazing.
of centers with MTPs.
Amazing, because this will help us to develop ours actually in our Saudi Arabia and even in Gulf countries as well. Last question
It's not
before we end
easy,
up.
right? It's not easy to develop MTP,
Yeah,
even for the adults. So it's much more difficult in the
yeah,
pediatric age group.
I agree. Last question before we end our talk. In the era of developing guidelines and protocols, would you recommend to establish a pediatric advanced trauma life support certification course or protocol for our population?
Advanced pediatric trauma life support course.
Yes.
Yeah, if you have one, why not?
Oh, I mean,
It's
a great
always
answer.
good. It's always good to have, more training, more exposures, right? Won't do the won't do us any harm, but does us a lot of good. So I'm not quite sure there's advanced pediatric life support training. The advanced pediatric life support course, the APLS course,
Uh-huh.
has a chapter on injury. So that's quite detailed inside it on top of their other medical cases. So we're looking whether it goes together with the ATLS, but so far the basic concepts of it is the same. So, but as a pediatric life support, a trauma life support, I've not seen that before yet.
Yeah, it will be one of a kind that we're thinking about establishing it soon in our Saudi
Since you're a
Arabia.
pediatric hospital, carry on.
Yeah, inshallah. So thank you so much, Dr. Sabariah. It was really an inspiring and practice changing session that reminded us how evidence, systems, and teamwork truly save small lives in pediatric trauma. And thank you for your expertise so much. And inshallah, we'll see you soon in Riyadh.
So thank you for having me as one of your speakers. I hope to go to Riyadh again, meet
Inshallah.
up with Yara and you guys, and of course do the Umrah and
Inshallah.
do I see Medina. Thank you very
And
much.
thank you
Assalamualaikum
so much.
warahmatullahi wabarakatuh.
Wa alaikum salam. Bye.
Bye.